Good evening and welcome everyone. My name is Charles Broadfoot. I'm a Professional Development Officer with the PHN for the Hunter region. I'd firstly like to acknowledge the traditional custodians of the lands in which we are meeting tonight and pay my respects to elders past, present and emerging, and welcome our Aboriginal friends and colleagues who are also joining us tonight. So tonight is our second wound care webinar in a series of 3. And it is sponsored by Hartman. So some of Hartman's products will be mentioned, but this does not mean that you have to use them. We obviously encourage you to use your own clinical judgment on what will best work for you and your practice. So on the right-hand side of your screen is a chat pane in the control panel, and you can use this to ask any questions, and you can do that throughout the presentation. There'll also be some time at the end where Sarah will be able to answer any outstanding questions as well. So we really value your feedback, and we'd ask you to please complete the evaluation poll at the end of the webinar, and this will pop up on your screen when the session ends. So a recording of tonight's webinar and the slides will be available on our People Bank site. So you just have to head to the PHN website, click on the People Bank link, and then from there you click on the Education and Events tab. So I would like to reintroduce tonight's speaker, Sarah Ford. So Sarah is a registered nurse and the National Clinical Educator with Hartman Australia. So without further ado, I'll hand over to you, Sarah. Thanks very much.
Thanks, Charles. Just wait for my screen to, oh, maybe, no, I'm already sharing my screen, aren't I? Great. Okay, welcome everyone. Thank you all very much for attending tonight. I would like to start this evening by letting you know that, oh, I'll just get myself organised here. There we go. We'll be focusing on hard to heal wounds tonight and their treatment based on the time concept. So the topics we'll be covering are why some wounds are so slow to heal and the importance of wound assessment. We'll look at wound bed preparation and time and the benefits of wound hygiene. We'll provide an overview of the treatment of hard to heal wounds and look at simplifying the dressing selection so that it's based on the patient and the wound's needs. And we'll finish up with a summary and the opportunity for you to ask some questions. So it's always really important to understand exactly what you're dealing with when you're looking at a chronic wound, or as I like to put it, a hard to heal wound. Here's a definition which is simple and describes the problem exactly. Chronic wounds are defined as a wound that fails to proceed through the normal phases of wound healing in an orderly and timely manner. The wounds just become stuck and fail to proceed no matter what you do, and I'm sure you're all very familiar with this problem. So why won't they heal? In the first webinar, we discussed the stages of wound healing in a healthy person. The wound bleeds and then clots formed, and the area around the wound becomes inflamed, leading to the inflammatory stage of healing. During this stage, bacteria are killed and debris is cleaned away. Growth factors encourage the growth of new blood vessels and granulation tissue within an extracellular matrix. The wound progresses into the proliferative stage and the wound becomes stronger with a lot of new growth of tissue and the migration of epithelial cells across the new granulation tissue to close the wound. Finally, once the wound is closed over, the maturation or remodeling stage increases the strength of the wound. The appearance becomes similar to the surrounding skin and the epidermis thickens up. This process takes between 4 to 6 weeks, but that will of course depend on the severity and location of the wound. Always remember though that this area will always be weaker than the surrounding tissue and therefore needs to be given extra consideration when assessing a patient. Chronic inflammation. A wound that has become stuck or been present for longer than 6 weeks is classified as a chronic or hard to heal wound. And I mentioned that in the last webinar, that the term chronic has such a negative connotation that I've taken on board what Christine Murphy, the chair of the panel of expert advisors who wrote the consensus document on hard to heal wounds and wound hygiene, said, and I'm trying to change and refer to them as hard to heal wounds instead of chronic wounds, which seems a bit more positive and hopefully not have such negative connotations. These wounds become stuck in this phase of healing and get out of cellular balance, and as a result of other contributing factors such as diabetes or peripheral vascular disease, the body's lost its ability to produce the cells that allow the wound to progress through the normal phases of healing. So it just becomes stuck in that inflammatory phase. And why does this happen? Matrix metalloproteinases are enzymes that play a pivotal role in the normal wound healing process. We also refer to them as MMPs. They're produced by the inflammatory cells, the neutrophils and the macrophages and other cells involved in wound healing, such as epidermal cells and fibroblasts. And their role is to clear away the debris and damaged tissue and promote growth of new blood vessels to provide oxygen and nutrition for healing. In a healthy wound, they're regulated by the tissue inhibiting MMPs, known as the TIMPs, which block their activation and allow the wound to progress on through these stages of healing. I see them as a bit like the riot police that take control of a large crowd of people and prevent them overrunning the city. In hard to heal wounds, these TIMPs or regulators are completely overwhelmed and don't have the ability to take control of the MMPs. Therefore, the wound becomes overrun with MMPs who start eating away at any new tissue that forms, preventing the wound from progressing. The wound becomes out of balance and it creates a highly destructive environment. As the new granulation tissue tries to grow, it gets destroyed by the MMPs and the wound becomes stalled, which is known as chronic inflammation. Back in 1999, Trengrove et al. Identified the difference between the level of MMPs in an acute wound compared to that of a hard to heal wound. And you can see here how on the right-hand side of the slide, can I get my pointer up there? In the acute wound, the level of MMPs is very low compared to venous leg ulcers, arterial ulcers, diabetic foot ulcers and pressure injuries. To me, this highlights the key role the MMPs have in delaying wound healing, as it clearly shows this differentiation between acute wounds and hard to heal wounds. Here is the vicious cycle that the wound gets into, preventing it from progressing. The MMPs destroy the growth factors, preventing the stimulation of new granulation tissue. In this destructive environment, there's an increase in bacterial load, and this leads to an increase in exudate as a result of the continued inflammatory response and the presence of high levels of bacteria. As part of that inflammatory response, more MMPs are produced, which continue to destroy tissue and create an imbalance as their regulators, the TIMPs, are outnumbered and cannot restore the balance. And around it goes. So this, in a nutshell, is why these wounds don't progress. But of course, this all happens as a result of other factors that impact the ability of the body to do what it's meant to do and heal. We need to understand what systemic factors will cause the delay in healing, which comes with good holistic assessment. So we briefly talked about the importance of assessment in the previous webinar, but I'd just like to recap and highlight some of the key points. Some of the diseases that can impact healing are diabetes. Uncontrolled blood sugar levels reduce the ability to heal, and in addition, microvascular disease reduces the blood supply to the area and impairs nerve function. Diabetes also impairs the production of leukocytes, which reduces the ability of the person to fight infection. Anemia reduces the supply of circulating red blood cells, impacting the supply of oxygen to the tissues. Growing malignant tumours may impact blood supply to the area, and the patient's treatment to kill malignant cells will impact on healing, as well as their nutritional state. Patients with rheumatoid arthritis are often on anti-inflammatory medications, which will suppress their inflammatory response, making it difficult for the right healing cells to get to the wound to stimulate the healing trajectory. Autoimmune disorders have an impact on the inflammatory healing process and reduce the person's ability to fight infection. Hepatic failure reduces the level of circulating hemoglobin and therefore the ability to eliminate toxins from the body. And finally, inflammatory bowel disease results in a poor nutritional state, reducing the ability to fight infection, as well as repair and grow new tissue. Malnutrition and dehydration have been shown to delay wound healing and increase wound infections. Our body needs nutrients for regeneration and repair of tissue. Exudate is high in protein, so the more that's present, the more protein is lost and needs replenishing. People with hard to heal wounds require extra kilojoules and protein for tissue growth and repair. There can be competition for limited nutrients such as amino acids required for cellular energy and the effectiveness of medications. Essential amino acids are found in meat, fish, lentils, and dairy. Water comprises 60% of our body weight and is essential for tissue viability. Dehydration can affect a person's appetite, increase confusion, and make them constipated. When you think of the elderly and how little they eat and drink, it's easy to see why they become so malnourished and dehydrated. Obesity and cachexia lead to poorly vascularized tissue, or high levels of obesity lead to poorly vascularized tissue, therefore making it difficult to heal, especially under tension, which is often the case in people who are morbidly obese. And of course, at the other end of the spectrum, physical wasting as a result of reduced nutritional intake will also impact wound healing, as there's little adipose tissue for protection, and that can quickly lead to skin breakdown from pressure. A lack of sensation can lead to an injury occurring without even being aware of it. Sensation is part of our protection mechanism, and if we don't feel pain, we don't know when our body is in danger. Drug therapy, such as anti-inflammatories, cytotoxics, steroids, antibiotics, anticoagulants, and of course nicotine, are commonly used drugs that will impact healing. Radiation therapy destroys both malignant cells as well as the new cells and causes vomiting and diarrhea, which diminishes the nutritional state. Stress, pain, and anxiety have all been shown to reduce the efficiency of the immune system, which will retard healing. So there are so many different factors that can so easily impact a person's ability to heal that we need to be extremely thorough in our investigating to fully understand the patient's health and what can slow their healing. Now we're going to look at wound bed preparation and time. Wound bed preparation was first described in 2003 by an international panel of key global clinicians when they looked at the rate of wound healing and saw that there was still a high level of chronic wounds in their clinics and patients suffering with these chronic wounds that weren't healing. They needed something that was going to be easy for people to understand and understand why these wounds weren't healing. This concept was first defined by Schultz et al. In 2003 as a management of the wound to accelerate endogenous healing and to facilitate the effectiveness of other therapeutic measures. With the understanding of the impact of hard-to-heal wounds on a person's quality of life, their family and carers, the economic burden, and evidence related to biofilm, etc., this framework has been developed with hard-to-heal wounds in mind. Understanding the healing objectives for each individual is essential. Share with the patient and their family realistic expectations around the possibility of the wound actually healing. Most wounds have the ability to heal, but as we've just discussed, there are many factors that slow the process and in some cases make it impossible for the wound to heal. In this instance, the focus will be on keeping the patient's quality of life at the forefront of care. Once all the holistic considerations have been considered or taken care of, then we look at the wound and break it down into 4 key areas: tissue management, inflammation or infection, moisture balance, and finally, epithelial edge advancement, or time as it's known. So let's look at each of these individually. T equals dead tissue or tissue deficit. All dead tissue sitting on the surface of a wound is going to be a haven for bacteria, block the progress of the wound, and hide the true depth of the wound. This non-viable tissue can be called eschar, necrosis, or slough. Clinicians refer to the dry, leathery, dead tissue as eschar, which is often seen in burns. Necrosis is the umbrella term for all dead tissue, but is often used to describe the black or grey dry dead tissue. And the yellow-brown moist tissue associated with slow healing wounds is commonly referred to as slough. No matter what it's called, there's dead tissue present and it needs to be removed before the wound can progress, so as it's blocking the growth and progress of the wound. Any deficit of tissue must be filled to ensure the wound heals from the base upwards. A cavity wound needs to be lightly packed to prevent the skin edges from closing over prematurely and ensuring the wound can granulate up from the base. And you can see here on the bottom image on the right-hand side how those skin edges really want to close over, but the granulation tissue hasn't increased from the base up, which it really needs to, before the skin edges can close over, or you end up with an abscess. So it's really important to pack those cavity wounds so the wound heals from the base upwards. Wound photography and accurate measurement are essential for good documentation and ongoing treatment to understand if the care you're delivering is being effective. I for infection or chronic inflammation. This document is a great resource, and much of what I'm presenting tonight is on infection is from this document from the International Wound Infection in Clinical Practice, International Wound Infection Institute on Wound Infection and Clinical Practice, the Principles of Best Practice. I really recommend that you download it from the website and have a read. It is actually free. You can see the website on the bottom of the page there. I'll give you a minute to write it down, but don't forget that these slides are also coming out to you, so you can actually refer back to them after this webinar tonight. This is the wound infection continuum discussed in this booklet that I've mentioned. It demonstrates the stages the wound progresses through if the bacteria is allowed to take hold. And as you can see from this diagram, no antimicrobials are indicated until the wound starts to demonstrate signs of local infection. Then it recommends topical antimicrobials. As the deterioration extends into spreading infection, this is when systemic antibiotics and antimicrobials work together to control the infection. This document also talks about overt and covert infection. The overt signs are the obvious ones: pain, redness, heat, swelling, pus, and are demonstrated in a healthy person who's fighting infection. We've all seen those signs of an infected wound in a healthy person. They're easy to pick up on, and the person is often complaining of the pain they're in. Covert signs, on the other hand, are much less obvious and present in hard-to-heal wounds, but due to their disease process, they're not clearly demonstrated. It takes a bit more detective work to identify an infection in a hard-to-heal wound. Things like delayed healing, increase in pain, and local skin temperature, as well as changes in the volume and the odour of the exudate, are all significant signs of a wound infection in a hard-to-heal wound. Sometimes it may be just that the patient feels off colour, or they may seem a bit confused. Cellulitis can be present in both overt and covert wound infections. A healthy body is designed to fight bacteria. However, people with hard-to-heal wounds are not healthy, and therefore they struggle to fight bacteria. Bacteria live and grow on our skin, so if there's a break in the skin integrity, it's easy for this bacteria to infiltrate the wound and multiply, especially if it's in an area that has a high bacterial load, such as the perineal area and the anorectal area. If the environment is right, they'll take hold and infect the wound. As many of these wounds have been present for a long time, bacteria have moved in and been able to settle on the wound bed and live comfortably. The body isn't able to fight them, and they just settle down and form little colonies. They're able to communicate with each other and build a slime coating over the surface to protect themselves, which is called a biofilm. We should assume that all hard-to-heal wounds are coated in a biofilm, because you can't actually see it with your naked eye. It's similar to when you forget to clean your teeth, and as the hours tick by, your teeth start to feel slimy. This is a biofilm as well. These biofilms need to be removed. When we're brushing, flossing, and rinsing our teeth, we're actually debriding that biofilm to break it up and remove the bacteria. We repeat it on a regular basis to prevent the biofilm from returning. In wound care, it's the same principle. The most effective way to remove the biofilm is with regular debridement. Many clinicians are reluctant to carry out debridement, but there are many different ways to effectively debride a wound. In addition, the risk of infection and the resulting biofilm, we also need to consider chronic inflammation, which we've already discussed. Excess MMPs preventing the wound from progressing, resulting in the wound becoming stuck in the inflammatory stage of healing. Sharp wound debridement can create an acute wound response, which will kickstart the wound again into a healing trajectory, as well as removing any bacteria and debris that might be blocking the wound's progress. So it's actually a really good thing to start debridement and create that acute wound response. M is for moisture balance. Now let's look at getting the moisture balance correct. All wounds need to have the correct moisture balance. Too dry and the new granulation tissue can't grow, and the epidermal cells can't migrate across the wound bed. Too moist and the tissue becomes macerated or soggy and non-viable. Therefore, the amount of exudate coming from the wound always needs to be assessed, and the dressing selected needs to be able to absorb the exudate and provide enough moisture for healing to take place. It's the Goldilocks theory. Hard to heal wound fluid is very different from acute wound fluid. In an acute wound, the fluid is clear and clean and full of good healing enzymes designed to help heal the wound. In a hard to heal wound, the fluid is full of bacteria, dead cells and debris that's toxic to the wound bed and the edge of the wound and needs to be removed. Malodor, leakage, strike through, all resulting from a wound with high levels of exudate that hasn't been controlled properly, leads to embarrassment, social isolation and depression. I can't emphasize enough how important it is to ensure the dressing you choose will provide comfort, manage exudate, and ensure the patient can enjoy the best possible quality of life. E is for edge of the wound. Finally, we look at using the edge of the wound to help us understand what's happening with the wound. A lack of progress of the wound edges is an indicator that there's a problem. The wound edges can sometimes help to identify the problem. Redness can indicate there's an infection. Maceration indicates too much moisture on the wound and it's spilling onto the edges. Callus is like a brick wall around the wound, and healing can't take place until the callus has been removed. No progress will mean going back and reviewing the patient and the wound again to understand why it's not progressing. The wound edges are an excellent guide to help you understand the progress. As I mentioned earlier, wounds should always be measured and photographs taken to provide an accurate record of the wound's progress. Wound hygiene. Again, wound hygiene is a similar concept to oral hygiene that supports meticulous wound practice to address the barriers to wound healing, such as biofilm, while aligning with biofilm-based wound care and antimicrobial stewardship programs to prevent bacterial resistance. To me, it's common sense care of the wound and should be something that's attended to at each dressing change. Step 1, really thoroughly cleaning the wound with a gauze or commercially available cleansing pad and an antiseptic or surfactant wash to remove dead skin and tissue, as well as any old blood or debris that may lead to infection down the track. Cleanse peri-wound skin to remove dead skin and scales and callus, and to decontaminate it using gentle force while necessary and where necessary and as tolerated. It's to be done at every dressing change. Step 2, debridement of any dead tissue, foreign bodies or biofilm. Continue until pinpoint bleeding occurs, of course, with the patient consent and if the patient can tolerate it. I remember when I was learning about this and listening to a webinar and they were talking about this. It's often a concern that many patients find this too painful to tolerate. But if your patient is able to control the amount of debriding that you do and cleaning that you do and tells you when they want you to stop, they are quite happy, as this clinician was talking about it, to allow you to clean it as much as possible, as they feel it really is benefiting them and helping to improve that wound healing outcome. It'll leave the wound in the best possible condition to get the most out of the dressing to be applied, such as an antimicrobial dressing or a dressing that will continue to cleanse the wound. Step 3 is refashioning of the wound edges to remove any necrotic or crusty or overhanging parts that may be non-viable and can harbour bacteria and biofilm, as well as ensuring a continuation of the edges of the wound with the wound bed to facilitate wound advancement. So we don't want cliffs, we want beaches, and I'll explain that a bit more in the next slide. Step 4, apply a dressing that'll manage the residual bacteria on the wound and remove the exudate away from the wound. Even though this is common sense approach to wound management has been around for years, it's only recently been written up in this really informative paper, Defying Hard to Heal Wound with an Early Antibiofilm Intervention Strategies. I've referenced it at the bottom here, and it can be purchased from the Journal of Wound Care website. So in step 3, when they talk about refashioning of wound edges, ensuring a continuation of the wound edges with the wound bed to encourage wound advancement, this is what they mean. And you can see here on the right-hand side how the wound edges are a bit like cliffs, and the epithelial cells will find it very difficult to progress across this area. So these need to be cleaned away and gently debrided so that the epithelial margins can actually progress inwards as they are in the image on the left-hand side there. Beaches, not cliffs. Now we're going to look at treatment options. We're going to take a bit of a look at product selection, and this guide is a step-by-step approach to selecting the right product for the needs of the wound. Step 1, assess the wound using the TIME acronym. Step 2, identify the needs of the wound, whether it's clean, absorb, hydrate, or protect. And step 3, choose the right dressing based on the identified needs of the wound. Now, for those of you who've requested a copy of this wound chart, we'll include a copy of this on our next newsletter to you. It's important to understand what dressings you have in the cupboard and understand if you have a dressing that will do each of these things: cleaning, absorbing, hydrating, and protecting. It makes it much simpler for clinicians to identify which dressing they need to select for which wound, not have too many dressings that do the same thing. What's your clinical aim? Clean debris from the wound bed and the wound surface, absorb, exudate, and debris from the wound, rehydrate a dry wound to promote new growth, or of course protect the wound while it's healing in that delicate end stage of healing. Cleaning the wound involves applying a cleaning solution to wash the wound bed to remove bacteria, exudate, and debris. Once the wound's been washed, if there's a coating of dead tissue that needs removing, then we need to use a debriding agent. There are many options available, and it's really dependent on the wound and the patient's circumstances, which one is the right one for each wound. Surgical debridement is performed in the operating theatre or treatment room under aseptic techniques. Generally, it requires an anaesthetic and is suitable for larger areas of debridement, such as major burns. Sharp wound debridement is performed by a medical practitioner or podiatrist or a nurse practitioner. It's non-selective and also requires anaesthetic unless the area is insensate. Conservative sharp wound debridement can be performed by an RN trained in debridement. It's ideal for removing avascular insensate tissue, provided that there's enough circulation to support healing. Autolytic debridement is selective debridement not harmful to granulation tissue or epithelial tissue and more comfortable for the patients. Mechanical debridement is appropriate for extensive tissue necrosis, for example, whirlpool or hydrotherapy, but can also be a monofilament pad used to rub the wound bed to physically remove the dead tissue. Another form, not so commonly used anymore, I hope, are wet to dry dressings, which are painful and non-selective in the tissue they remove. Low-frequency ultrasound is a fast and efficient way of debriding a wound and has a bactericidal effect, but the technology is expensive and it's not always available. Chemical debridement involves bactericidal and bacteriostatic agents, but may be cytotoxic to the healthy cells on the wound bed. And lastly, larval therapy. It's fast and efficient, but not always acceptable to the patients, and can be difficult to obtain the sterile larvae, as they're limited in their availability and can be expensive. HydroClean Plus is a dressing that will provide autolytic debridement of the wound. The objective of the dressing is to clean the wound and kickstart healing. It has the ability to rinse the wound bed as well as debriding and absorbing the bacteria and debris-laden exudate up into the dressing. It efficiently debrides slough and necrotic tissue, traps and kills bacteria, and kickstarts the wound healing in both dry and exuding wounds. In addition, the constant rinsing action by the Ringer's solution that's released onto the wound bed will reduce pain on the wound bed as well as bathing the nerve endings in moisture to help with that pain levels. Here are some examples of the effect of HydroClean Plus on sloughy tissue. And you can see on the image on the left-hand side, wound A is free of sloughy tissue after 12 weeks, and on the right-hand side, wound B after 3 weeks. On a wound that has a low level of exudate, all you need to do is apply the dressing and cover with a film to hold it in place. Never cut the dressing because it contains superabsorbent polymers which hold onto the wound fluid. And if you cut the dressing, they'll spill out onto the wound. If it sits on the skin edges and is a little bit big, apply a barrier cream or wipe to protect them from the moisture of the dressing. If the wound is exuding, then apply the HydroClean Plus and cover it with an absorbent pad such as Zechavit Plus or Zechavit Plus silicone border and secure with some tape. Atraumin AG is a silver dressing designed to kill bacteria in the exudate as it is absorbed up into the secondary dressing. It protects the wound from infection, and following the removal of biofilm by debridement is an excellent way of keeping the wound from becoming reinfected. There are many silver dressings on the market today, and it can be very confusing. Some contain a higher level of silver than others, and some are absorbent and some donate silver to the wound bed. So it's really important to go through and research each of the silver dressings that are available so you know which one is right for you. There's no direct comparison to Atraumin AG. It's a chill dressing coated in silver. Other silver dressings include Acticoat, Aquacel AG and Mepilex AG. The advantage of Atraumin AG is that absorbent silver dressings are, when placed on a wound bed and left in place, they are absorbed to capacity and then need to be changed because they're an all-in-one dressing. Whereas the Atraumin AG, you can lie it on the wound bed. It acts as a wound contact layer, allowing the exudate to pass through that into the secondary dressing, which can be changed as often as needed, and you don't need to change the Atraumin AG. It has a lower level of silver, which makes it less toxic to the new granulation tissue than other silver dressings with a higher silver content. Here are some examples of the type of wounds that would be suitable for Atraumin AG. Silver dressings will not debride wounds. They're designed to kill bacteria. People who are vulnerable to infection, the elderly, those with comorbidities such as diabetes or superficial wounds that look as though they may be infected, are all wounds that would be ideal for Atraumin AG. So where does Atraumin AG fit on this continuum? And what about HydroClean Plus? You can see here that they work side by side, depending on the action required. Atraumin AG is for wounds with a lower level of bacterial burden or wound infection, and HydroClean Plus will debride the wound, removing bacteria and breaking up biofilm and sloughy tissue. Managing the exudate can be the most difficult part of the dressing selection. Always assess the old dressing when you remove it from the wound to see how it's handled the exudate level. This will help you decide whether the dressing was suitable for that wound or not. Absorbing or hydrating. Absorbing heavy exudate with an absorbent dressing such as Zechavit Plus will work really effectively to not only manage that exudate level, but it also manages the level of bacteria on the surface of the wound and the debris and other cells that are not wanted on the surface of the wound. It contains superabsorbent polymers to hold large amounts of exudate, and it will hold on to the exudate even under compression. If you want to hydrate the wound, if it's a dry wound, use HydroClean Plus or a hydrogel to add moisture and encourage the growth of new tissue, as well as cleaning the wound bed of dead tissue and bacteria. Zecuvit Plus Silicone Border is a new addition to the Hartmann range of dressings, and it's designed to effectively manage moisture and protect the wound bed while it's healing. It'll provide peace of mind for those wounds that have to be left over a few days without a change, knowing that this dressing will handle exudate and protect the peri-wound skin. The silicone wound contact layer will enable easy atraumatic removal, while the waterproof backing layer provides protection, enabling the patient to shower and wear for an extended period of time. Like Zecuvit Plus, it has that superabsorbent polymers in the core of the dressing to hold large amounts of exudate, even under compression. This dressing is ideal for both moderate exudate levels to wounds with higher levels of exudate, providing versatility and protection for the peri-wound skin and reduction in odour levels to help improve the quality of the life of the patient. There are some wounds that just need protection while they heal. Hydratac is an example of a foam dressing that will provide protection for the peri-wound skin and encourage the growth and migration of new epithelial cells across the wound bed. It absorbs any moisture from the wound, and the hydrogel wound contact layer provides gentle protection as well as accelerating healing. The waterproof backing layer on Hydratac will enable showering and keep the wound protected from bacterial invasion. So this dressing will be ideal for somebody who has a wound that's clean and granulated and ready to epithelialize and just needs some protection. So in summary, wound management can be complex, but by taking a few simple steps, this complexity can be reduced. Step 1, conduct a thorough systemic and local assessment to understand the needs of the patient and their wound. Step 2, address the identified issues, put together a treatment plan and discuss the plan with your patient and their family, and document the findings accurately. Step 3, practice wound hygiene at every dressing change and select a suitable dressing to meet the identified needs of the wound. Step 4, review and reassess regularly to ensure progress is in the right direction. If you'd like a primary care sample pack, please email this email address, primarycare.inquiries@hartmann.info. Now, are there any questions?
We've got the first question is, can you talk about debridement when there are vascular issues and what precautions should be taken?
Yes. So the question was, in case you didn't hear it, can you talk about debridement when there are vascular issues and what precautions should be taken? And absolutely, if you have somebody who has a dry necrotic coated wound on a lower leg, or if your patient has identified vascular issues and they have sloughy tissue on the surface of the wound, that should not be debrided unless they have been assessed by a vascular surgeon or physician to identify the level of arterial impairment. Never debride dry, hard, stable necrotic tissue. It is an indication that the body has closed off that area, and that stable necrotic tissue is there to protect that person from further invasion of bacteria. So you would cover that and protect it to ensure that that person doesn't develop any further infection. So anyone with questionable vascularity needs to have further assessment to fully understand their arterial circulation before any debridement takes place.
I think you've answered this one, but what's your recommendation for autolytic debridement?
What's your recommendation for autolytic debridement? I would suggest that you try HydroClean Plus, because it works really nicely for people who have sloughy tissue on the wound. It donates that Ringer's solution to loosen or soften that necrotic tissue or sloughy tissue and lift it off the wound bed. But in addition to that, the constant rinsing will reduce the pain on the wound bed, and patients become very compliant with that dressing because they find it actually relieves the pain on the surface of the wound if they have any. It works really well to also control the bacterial burden as the bacteria are drawn up into the dressing and killed once they're taken up into the dressing. And it also promotes the growth of new granulation tissue. But if you don't have access to HydroClean Plus, then I would suggest using a wound hydrogel, and there are a number of different companies that have very effective wound hydrogels that will work effectively on the surface of the wound to debride that sloughy tissue.
The next question is, where can an RN do debridement certification?
Where can an RN do debridement certification? Well, I happen to know that Wendy White, who's a wound consultant in the Hunter area, I think she's based at Woy Woy, I think, does courses in debridement. I've done that course. It's a really excellent course, and she runs those, I think, on a fairly regular basis. So you could go there to get training in debridement.
The next question is, what cleaning solution or solutions and debridement solutions are recommended in general practice?
So what cleaning solutions? There are a number of cleaning solutions that are available. There's Prontosan, which is something that these are solutions that we don't have at Hartman, so you'll have to investigate where to get them from. But there's Macrodiacin, there's another one called Octenolin, I think, something like that. So there are a number of cleaning solutions available through your local distributors, I would imagine. You just have to ask them what they have available.
The next question is...
I just wanted to say, with Wendy White, you could Google the name Wendy White Wound Care, I think, and that will give you her details if you wanted to find out more about where to go to get training in debridement.
The next question is, what's the cost of HydroClean Plus dressing and how often do they need changing?
So the cost of what is the cost of the HydroClean Plus dressing? It's similar to Iodosorb. If you've used Iodosorb at all before, it's a similar price to that. I don't know the pricing because I'm not involved in that side of the business. So I just look after the products and the wounds rather than the actual cost of the dressings. I'm afraid I can't help you, but if you want further information, get in touch with your distributor and they'll be able to tell you the pricing. And the dressing, of course, like all dressings, how long do you leave it on the wound for will depend on the level of exudate. If it's a low level of exudate, it can stay on for up to 3 days. But if it's a higher level of exudate, you can, of course, put a absorbent dressing on over the top of it to allow it to stay on a bit longer. But if you may need to change it initially every day, every couple of days, until it starts to settle down and the biofilm, the bacteria and the sloughy tissue have gone, and you have a lower level of exudate. So gradually that will reduce, and then you'll be able to leave it on for up to 3 days. But it'll quickly clean that wound bed, so you won't have to change it as frequently for a very, for a short period of time.
This is a question. How do you make patients stop smoking? You got any hints?
How do you make patients stop smoking? I don't know. I can't help you with that one. I'm sorry. If I knew that, I'd be a wealthy, wealthy woman. I wouldn't be here right now.
Is Prontosan solution or a gel appropriate for removing slough?
Is Prontosan gel appropriate for removing slough? Yes, I believe it is. And it certainly works very well to break down the biofilm, I believe. But you'd have to talk to the people at B. Braun about that to know further exactly what it does. But you can certainly use it in conjunction with our HydroClean Plus to help break down slough. So you clean the wound with the Prontosan and then you put on the HydroClean Plus. And that way you have a continuity of the debridement and antimicrobial action of the two dressings, because the Prontosan has PHMB in it, which is an antiseptic, which will help to kill the bacteria, and so does the HydroClean Plus, which, even though it's not donated to the wound, once the bacteria is absorbed into the dressing, then it will kill the bacteria inside the dressing.
So the next question is, wound care is often shared with community nursing and GP treatment room. How often do dressings need to be done, and what top 3 dressings would cover the basis, knowing that wound dressings are not covered by Medicare when providing treatment?
Oh, that's a big question, isn't it? And a hard one. I think that, you know, you really want to have a combination of dressings that will do a number of things and that are easy to use. So you want to have a really good debriding dressing, so something that will clean the wound bed and help to remove that sloughy tissue. You want to have something that's going to be an effective antimicrobial to kill the bacteria on the surface of the wound, and I think an absorbent dressing. So of course, I'm going to say HydroClean Plus to debride, Atrom and AG for wounds that are threatening to become infected or that you're worried about. But if you're really concerned that if there's a full-blown infection there and they have a high level of bacteria, then I would suggest something with a high level of silver in it, like Acticoat. And then for an absorbent dressing, then you want something that's going to manage higher levels of fluid or all levels of fluid. And I would suggest that the dressings with a super absorbent polymer in it would hold on to the fluid. So the Zetuvit Plus silicone border is a dressing that is gentle on the skin because it's got silicone on it and very absorbent and waterproof. So that's a flexible dressing that will accommodate all levels of exudate. So, you know, those 3 dressings would, or 3 or 4 dressings, I guess, with the 2 different silvers, would accommodate those 3 actions: the cleaning, the antimicrobial, and the management of exudate.
The next question is, what cleaning solution does Hartman have? We're not Hartman solution.
We don't have a cleaning solution, unfortunately. I know that there is one coming. Our German counterparts are developing one at the moment, but it's not here yet, unfortunately, so I can't help you there.
And just the last question was in relation to the slides, which will be available by the PHN.
Yes, we'll send out those slides to you tomorrow so you can have them to refer back to. And I just wanted to mention that next week, at the end of the webinar, we'll be doing a quiz to just recap on the information we've delivered in all 3 webinars. It's going to run through a platform called Kahoot, which is something that's available in the App Store on your phone. So all you have to do is go into your App Store and look up Kahoot, spelled K-A-H-O-O-T, and download that app onto your phone, and then you'll be ready to go for your quiz at the end of the webinar next week. And yes, and there are prizes at the end, so it's worth it. Nice prizes. There's a wound care manual and a $50 gift voucher for the first prize. $30 gift voucher for the second prize and $20 gift voucher for the third prize. So good prizes. All right, I'm going to hand back to Charles now, and thank you very much for your time this evening. Good night.
Thanks very much, Sarah. That was great. Really well put together, informative session with lots of practical information. I sure learned a few things myself, so that's great. Thank you again for spending time with us tonight. And thank you as well to Danielle in the background there reading out the questions. I did see a question pop up where the slides will be available. So they will be available through the PHN website. So if you just head to Hunter New England Central Coast PHN website, up the top you'll see a little People Bank button. Click that and then click Education and Events, and that's where we list and host all of our webinar recordings and slides. So that should be available from tomorrow. So our next and last webinar in this wound care series will be next Wednesday. So that's the 28th of October, and it will also be in the evening. And just lastly, we'd love your feedback. So if you could take some time to complete the evaluation, which will pop up when the session ends, yeah, we'd really appreciate it. So thank you again to Sarah and Hartman for a great presentation. And I just want to wish you all a safe evening, and we'll see you again soon. Thanks.
Thank you. Bye-bye.
Bye-bye.